We're talking about the slit lamp. We mentioned that it's formed of an illumination arm and the magnification arm. Both of them are coupled to fall at the same point. So the illumination arm is focused on the same point on which the magnification arm is focused. Unless you do uncoupling to illuminate another point. It's formed of an eyepiece, and the eyepiece you can control the magnification, and you should use the correct power of the eyepiece so that you don't need to accommodate. What you need to do is to dial the eyepiece counterclockwise till the end, and then move it clockwise slowly till you start to get a focused image. By that, you will ensure that you are using the maximum plus and you are not doing accommodation. We can change the magnification from the lever here in the Hagstreit model or from the roulette here in the Zeiss model of the slit lamp. Okay. And if we talk about the optics, we have the eyepiece, which is an astronomic telescope formed of two convex lenses, which will end up giving an inverted image. We have a Galilean telescope towards the observed eye. It's formed of a convex and a concave lens, which will end up giving an erect image. And then we have what we call an objective lens to focus the image for near. And we need to have a prism to invert the image before passing through the astronomic telescope, because otherwise the image will be inverted like the indirect ophthalmoscope. But this prism will invert the inverted images and we will end up having an erect image. Okay. We have the Zeiss type. Illumination is in the lower part of the ophthalmoscope, like here, or we have the Hagstreit type, the one that we use more commonly, the illumination in the upper part of the slit lamp, like that. Okay. You should know about the filters. So we have what we call the heat absorption filter. It's like a yellow filter to decrease the patient discomfort during the examination. We have the gray filter, in which the light intensity is reduced. We have the red-green filter, which gives a green light. It's better to visualize the red lesions like neovascularization, like retinal hemorrhages, etc. They are better to be observed with the red-free light. And then we have the cobalt blue light, which gives a blue light with a wavelength of 450 to 500 nanometers. And it's used to, when you use fluorescein dye to stain a corneal ulcer or a corneal erosion, or during a CDL test, or during the intraocular pressure measurement. Okay. Other than that, we have this small lever, which helps you to control the height of the beam, and you can change the direction of the beam by rotating this part to the right and to the left. As you can see here, there is a small scale. For example, if it's here at 90, then the light is vertical. You can change it to 0 or 180, and the slit will become horizontal. You should know about the methods of illumination that you can use with the slit lamp. So the first of them is called the diffuse illumination. You use a wide beam, and you may want to use the diffuser. This is called the diffuser. You lift it up, and it causes the light to be diffused rather than being focused. And it gives a general overview of the eye before starting to examine each eye in details. Okay. Then you should remove the diffuser and narrow the beam of the light and do what we call the direct focal illumination, or what we call the optical section. The whole idea about the slit lamp, it's just like if you get an apple or an orange and you cut it in half and you start to look at the layers of the orange. So there is a cover of the orange at the outside, then you have the inside of the orange, etc. We do the same in the eye using the light. We use the fact that the media of the front of the eye are transparent. So if you will make the light coming from one side and you look at an angle, you'll find that the light is passing through the cornea first, and then through the anterior chamber, and then falling on the iris lens diaphragm afterwards. So you use a full height of the beam, and you make it hairline to medium width, so you narrow the beam, and you use a high intensity light, and you put it oblique to the eye and look directly perpendicular to the eye. So here the viewing arm and the illuminating arms are parafocal, and it's useful for evaluating the depth of the lesion. So for example, we can see here that this opacity is at the outer part of the cornea near the epithelium, etc. Okay. Any problems with the optical section? So if we will decrease the height of the beam and make the slit a bit wider, it will give what this called the parallel piped illumination. So this is the appearance of the parallel pipe. It's one of the geometric shapes, and it's useful to get a clear 3D details of the cornea. So it's a bit wider than the optical section and a bit shorter than the optical section, and you can study the corneal opacities or corneal ulceration, the depth of that and the location of that very clearly. Okay, and then if you will play a bit with the light, make it a bit shorter and narrower, so make it with the width of 1 to 2 millimeters and a short beam of 1 to 2 millimeters, and pass it obliquely. This is called the conical beam, and it's useful to grade the anterior chamber cells and flare. So if you can see here, for example, the anterior chamber should be optically empty, so it should be jet black in color. But as you can see here, there is some increase in the protein of the anterior chamber, and this is why there is a bit of flare here. And if you will use high magnification, you may be able to see the small cells like dust, small dust particles floating in the anterior chamber. This is called the conical beam. Okay. Any problems up till now? Okay. We'll move on. Then we have what we call the specular reflection or the reflected illumination. So this is how the specular reflection looks like in nature. Just admit your colleagues. Okay. So this is how the specular reflection appears in nature. If you have a clear, very regular surface, the light will be reflected from the surface. And if this reflection is regular, it's called the specular reflection. If this water is, not very regular, it doesn't have very regular surface, then the reflection will not be clear, and it will give what we call the diffuse reflection. Like, for example, the reflection that comes from a wall or an opaque structure. So we use the same principle to study the eye. You want to see some details that are not visible with direct illumination or with optical section. So here what you do is you make a beam of light, and you make it fall obliquely on the surface of the eye, and you focus with high magnification on the inner surface of the cornea, on the endothelial surface of the cornea. So this is the stroma. I'm not looking at the stroma. I'm not looking at the light passing through the stroma. I'm focusing on the nearby area of the endothelium. And I may appreciate some abnormalities like cornea gattata, for example. So we bring the light with a wide angle of illumination, 50 to 60 degrees, and you should look directly perpendicular to the patient's eye, but slightly nasal to the visual axis of the patient. So you get the light from temporal, and you look slightly nasal. You don't look exactly where the light falls. Okay. Then another method is called the retro illumination or the trans illumination. So the light is reflected from deeper structure in the eye, like the lens. When you see the back of the iris, or the back of the cornea, or the back of the crystalline lens, or the back of a lens implant, the capsule, to appreciate PCO, for example, the light is coming from the back of the eye. So it's reddish in color because of it's reflected from the choriocapillaris. So this is why it has this reddish view. You may use that to illuminate iris transillumination, like pigmentary retinopathy, like pigmentary glaucoma, or patients with herpes simplex or herpes zoster who has sectoral or diffuse iris atrophy, like those patients, or patients with albinism, for example, like this one. You may use that. So the light here is coming from the side, and I'm not looking at the light. The light is crossing the cornea at that part and crossing the anterior surface of the lens at that part. I'm not looking at the area where the light falls. I just observe the area next to that, and I observe it against the reflection of the light from within the eye. It highlights a posterior subcapsular opacity here or a PCO here, okay? Then there is another method of illumination in which we do uncoupling of the light and the illumination. So the light is falling on one area and I observe another area. It's very similar to the retro illumination subtype of that. So I decouple the illumination and the magnification arm. I move the light slightly towards that side, and I don't look at the area illuminated by the light, but I look just next to that. Okay? And it's useful to see the subtle opacities against the dark background. This is called the indirect illumination. Okay? Then we have another thing called the sclerotic scatter. For example, in patients with corneal dystrophies, for example, a macular dystrophy or a granular dystrophy or these types of dystrophies, what you want to do is to bring the light obliquely at the edge of the limbus here, and then the light will, by total internal reflection, will passes inside the corneal substance, and if there is a corneal opacity, it will be reflected, and you'll be able to see the opacity clearer. This opacity may not be very visible if you use direct illumination, but it becomes more visible if you use indirect illumination or sclerotic scatter. Again, here you bring the light from the side, and there is a very subtle corneal opacity here that may be missed if you use direct illumination. Okay? Any problems with the methods of illumination with the slit lamp? Because we will move now to another subject. Anything that is not clear? انتوا فاهمين كل حاجة مش فاهمين حاجة خالص. طمنوني.
It's very clear, doctor. You can go on. Thank you.
Okay, thank you. Okay, so let's move to the fundus examination. With the slit lamp, it's impossible to observe beyond the anterior vitreous because of the refractive power of the ocular media, the cornea and the crystalline lens, okay? Because the punctum remotum is so distant so that the microscope cannot be focused posterior to the anterior vitreous. And then we need to do something to be able to observe the back of the eye, okay? So first of all, we need to dilate the pupils. We use either the parasympatholytic drops like the tropicamide or the cyclopentolate. Those are parasympatholytics. They block the parasympathetic supply to the constrictor pupillae, allowing the dilator pupillae to work unopposed. Or we use sympathomimetic like the phenylephrine. They stimulate the dilator pupillae and help the dilation of the pupil. So we have combination drops like cyclopentolate with phenylephrine, for example. So we can use different lenses to examine the back of the eye. One of them is called the ruby lens. This is called the ruby lens, okay? It's a biomicroscope mounted, so you don't hold it on hand. It's mounted on the microscope, on the slit lamp, as we will see in the next slide. And it's a non-contact lens. It's not supposed to touch the eye. It's either minus 55 diopter lens or minus 58 diopter lens. As you can notice, it's very similar to the diopteric power of the refractive media of the emmetropic eye, which is about 60 diopter. So what it does, it cancels the plus power of the refractive media of the eye and bring the punctum remotum of the eye anterior so that the slit lamp can focus on that point, because this punctum remotum is very far beyond the capability of the slit lamp to focus, okay? And it gives a virtual erect image. So the image is erect and it's not laterally reversed. So it's an erect image and it's virtual. Virtual means that you cannot focus it on a piece of paper or something like this, okay? Because the light is divergent and you see the image here. You cannot focus it here, okay? So it's mounted on the slit lamp like that, okay? And you use it. It has a small handle here, small handle here that you can use it to bring it closer or further away from the eye. And the magnification and the depth is similar to the 90 diopter lens, so it doesn't give a very high magnification like a 60 diopter lens, but it you can use it to examine mainly it has a narrow field of view, so you can use it, for example, to examine the optic disc, but not the peripheral retina. Okay. The main disadvantages, as I mentioned to you, has a small field of view, and it's difficult to focus the lens, and you need to use the joystick, move the joystick to move the lens back and forth, and use the bimicroscope to focus, to get a clear image. As you will see later on, you'll find that something like the indirect ophthalmoscope, it's not affected by the ametropia of the observed eye. So if the patient has high myopia or high hypermetropia, the image size is not affected. This is not the case with the ruby lens. Here, if the patient is hypermetropic or myopic, this will cause variation in the image size. Okay. And this will make the optic disc evaluation a bit more challenging, because there is, for example, the rule that larger optic discs are normal to have larger cups, and vice versa. So if you don't know the size of the optic disc, you may think that this is a larger than average cup, while it's actually a physiological cupping. Is that clear for you, or you want me to repeat? Okay.
Clear, doctor.
Okay.
Yeah.
Moving to the second type of lenses that we may use, the contact lens. So this, do you know the name of this one? What's the name of this lens? We use it frequently in our everyday practice.
Gonio lens, 3-mirror lens.
Exactly, it's Goldman 3-mirror lens, or Goldman or gonio lens. So it has a minus lens here to neutralize the plus power of the refractive media of the eye, and then rather than just seeing the central part through the lens like the ruby lens, it has mirrors. Those mirrors have different inclination. So for example, the small one, it's the gonio lens, it has very high inclination, and it's designed to examine the angle of the anterior chamber. The larger one has less inclination, and the big one has the least inclination. So this one will, the lens itself, you can observe the posterior pole through the lens itself. Then if you look at the big mirror, you will observe the green part here. The big mirror is has less inclination, so it's focused on the post-equatorial fundus. The medium-sized mirror, number 2, is focused on the equatorial fundus. So you see the ring number 2. And then the small one is the gonio lens. It has very high inclination, and it is supposed to examine the angle of the anterior chamber and the pre-equatorial retina. So the angles of inclination 67, 73, and 59 degrees. بنفتكرهم بحروب مصر سنة 73 و67 و 56 هي 59 بدل 56. Okay. So the advantage that they can be placed directly on the cornea after we put topical anesthesia, so that if the patient will blink with the other eye, the view will remain stable on that eye. They have better depth enhancement than the ruby lens, and the size is about 10% smaller than the ruby lens, but it has a slightly larger field of view. Okay. So moving to another one, you know, the ones that we use to do the PRP, for example, the super quad lens or the wide field lens. Those lenses have high plus power, and they come in contact with the eye like that. As you can see here, because they have high plus power, So the image is inverted and laterally reversed, and the image is real. So with the slit lamp, you focus on what we call an aerial image. There is an image in the air, and it's a true image rather than a virtual image. Okay, you can focus that on a piece of paper. Okay, so you have either the one with the high power, like this one. The high power enables to collect light from a larger field of view. So it's useful to treat the peripheral retina like doing PRP. The one with the smaller diopteric power, it has a smaller field of view, but it has better stereopsis. So you can use that to do macular laser because you want to have very good stereopsis to appreciate areas with thickening. You don't have to have a lens with very wide field. You are treating the macula. And as you may notice, the working distance of the 90 of the focal or the grid laser lens is it has a longer working distance than the high power PRP lens, because when you use a high power lens, it has a shorter focal length, so you need to bring it closer to the eye. But if you are using a less power lens, it has a longer focal length, and you need to keep it a bit further away from the eye. Okay, clear? Okay, so let's move to the non-contact condensing lens. So those have a variety of powers and a variety of, views. The rule is the larger the diopteric power of the lens, the less the magnification, and the worse the stereopsis, and the wider the field. So if you have two lenses, 90 diopter lens and 60 diopter lens, the 90 diopter lens will enable you to examine larger field, but the magnification is smaller and the stereopsis is not brilliant. On the contrary, you may want to use the 60 diopter lens to examine the macula because the magnification is brilliant, the stereopsis is great, and the field is not that good. Okay, the lenses may have a bit of yellowish tint to increase the patient comfort, and the refractive error of the emmetropic error of the patient, it has a small effect on the image size, unlike the ruby lens and the Goldman lens. Okay. The main disadvantages that you need to hold it properly in order to achieve a clear focus of the fundus, and if it's shifted, it may cause a prismatic shift of the view because the edge of the plus lens acts as a prism. So you always need to keep in the view at the middle part of the lens that you use. Okay, the magnification is less than the ruby and the fundus contact lens. Okay, so if we look here, you'll find that the 90 diopter lens, it has it gives a real image rather than as the virtual image seen by the ruby lens. The image is inverted and laterally reversed, unlike the ruby lens, which gives an erect image. You'll find that the field of view is big with the 90 or the 90 super field lens in comparison to the 60 or the 78 lens, and the magnification is less, so the image is more panoramic with the wide field lenses, the 90 diopter or the 90 diopter super field. Okay, and as you may notice, the working distance decreases with increasing the power of the lens. So for example, you want to hold the 60 diopter lens further away from the eye at the distance of about 11 millimeters, while the 90 diopter lens should be held very, very close to the eye. Okay. So this is how the view looks like in comparison of the 60 diopter lens and the 78 lens. The 60 lens is more magnified, better stereopsis, but a narrower field of view, while the 78 diopter has a larger field of view. Okay. Any problems with the lenses? Okay, moving to the next object, the direct ophthalmoscope. It has a handle with a battery, and then it has a bulb, and then it has apertures for the light source and a set of lenses inside here. And the view is monocular, so we use one eye. It's non-stereoscopic, so you cannot appreciate the depth. It has a narrow field of view in comparison to the condensing lenses that we mentioned before, but the magnification is very big, so the magnification is about 15 times. So the light is coming from a bulb, and then the light is reflected using a mirror or a prism to go inside the patient's eye, and then the reflected light will go coaxial to the illumination light and passes through a hole and then through a compensation lens to the observer's eye. The direct ophthalmoscope has what we call a lens wheel. So there is a wheel with different powers of lenses. When you dial this dial, you will bring the lens with the correct power in between your eye and the patient's eye to correct for your or the patient's ametropia. And then there is another wheel with different apertures, so you can use a small sized illumination or a large size illumination or a slit illumination, etc. For the lens wheel, the power is seen on the back of the ophthalmoscope. This is a Welsh Allen direct ophthalmoscope. It has a rheostat to turn on and turn off and control the intensity of the light. It has a rest here that rests against your eyebrow, and this surface faces the patient. There is a small mirror here to reflect the light towards the patient's eye. Okay. Okay, so we mentioned that there is a disc or a wheel, filters. You can use the filters to use a cobalt blue or a very bright light or a gray light if you wish. And you can adjust the brightness as we mentioned by the rheostat. So you press this button and turn it, and as you rotate it, the light will become more intense. So the main idea of the direct ophthalmoscope that if you are looking at the patient's eye, you cannot see the inside of the eye because there is no light going in. So we want some light to go in so that we can observe the reflected image. And this light source and the observer's eye need to be coaxial. They need to be aligned optically. So if you bring a light from your side, it will illuminate a different part of the eye from the area that you are looking at. So the whole idea that we want to bring this light to be aligned optically with the line of the sight that I'm looking at the patient's eyes through. This is the whole principle of the direct ophthalmoscope. Is that clear for you, or you want me to repeat it?
It's clear.
You want me to repeat it?
No, yes, please, Doctor.
Okay, I repeat it. The whole idea that if we bring the light, for example, from above my shoulder, the light is not aligned to the sight of my eye inside the patient's eye. So it's illuminating a different part of the patient's eye, and the part that I'm looking at will appear dark. The whole idea of the direct ophthalmoscope is to bring the illumination close to the ray of the observation, so that they pass close to each other and the light will go to the area that I'm observing in the patient's eye. We will observe that right now. So the illumination, as you can see, there is what we call the Gallstrand principle. The illumination is coming very close to the observation. This Gallstrand principle goes for the direct and for the indirect ophthalmoscope. In the direct ophthalmoscope, I'm observing only with one eye, so there is one image. In the indirect ophthalmoscope, I'm observing with both eyes, so there is one image falling on my right eye, and there is another image falling on my left eye. The whole idea that I want to squeeze those three rays, so the ray of the light going inside the patient's eye, and the ray reflected from the patient eye to the right doctor's eye and to the left doctor eye, I want to squeeze them all through the patient's pupil. I want to bring them close together to pass through the patient's pupil so that I'm observing an illuminated part. Okay? So we want to bring the light to pass very close to the light reflected to the observer's eye. So we can use either a semi-reflected mirror, so a mirror that will reflect some of the light, and at the same time it will allow the reflected light to pass through this mirror to the observer's eye. Or we use a perforated mirror, so a mirror with a perforation. The light will be reflected through the mirror, then the reflected light will pass through this perforation, and I observe the light coming through this small perforation. The ones that we use in our modern ophthalmoscopes is a small mirror that will reflect the light and allow the light to pass above it. So if you look at that part, if you have a direct ophthalmoscope and look at that part, there is a small mirror here. The light will come from here and be reflected to the patient's eye. Then the reflected light will pass from this small upper part in which there is no mirror. And both the illumination and the observation rays are very aligned optically. Okay, so why does the direct ophthalmoscope has a limited field of view? Because the illumination cannot the illumination of the direct ophthalmoscope cannot pass beyond a small limit here because of the limiting effect of the pupil. So if by one way or another we can illuminate larger area of the view, I can observe a larger area than the observed part. So the main problem is with the illumination system and not the viewing system. And you can observe that if you use a direct ophthalmoscope on a patient with dilated pupil, you can always find that you can still see beyond the area of illumination a bit, because usually the main problem that the pupil will hinder the light from passing to a more peripheral part of the fundus. The advantages of the direct ophthalmoscope: cheap and easy to use than the indirect. It has a better magnification. Usually the magnification is measured by dividing the diopteric power of the eye divided by 4. So if the diopteric power of an immetropic eye is 60 diopter divided by 4, it will give 15 times magnification. It's an excellent tool for assessing the posterior pole of the eye. The lens wheel allows you to adjust the focus. This can you can use so that you can use it for examining the anterior segment. If you want to examine the anterior segment, just dial more plus lens and the focus will become anterior and you'll be focused on the anterior segment rather than focused on the retina. Okay. It has auxiliary features like, for example, around aperture of variable size. You can change that from that wheel using a large size, medium size, small size, or a grid or a slit of light if you wish. And then you can change the filter. Some models will have a red free light filter or a cobalt blue light filter. For example, this particular head, it has only the red free and the gray filter, but some other models will have the blue cobalt blue light. Okay. Pupil dilation is very useful in direct ophthalmoscope examination because it allows more light to go inside the eye, so you can increase your field of view. As we mentioned, the main limiting factor of the field of the direct ophthalmoscope is the illumination. Okay. The main disadvantages with the direct ophthalmoscope is the limited field of view, the monocular view, so that you will not be able to appreciate the depth. One trick that you may use to appreciate the depth is to focus on the summit of the lesion. So let's say, for example, you have a retinoblastoma inside the eye, a retinoblastoma mass inside the eye. So you may want to focus on the top of the lesion or the summit of the lesion and check what is your diopteric power, what is the diopteric power that you used, and then focus on the retina itself and check what is the diopteric power. And if you, the larger the diopteric power difference between the summit and the floor of the lesion, the higher this lesion will be. Okay. Again, the illumination is dimmer than binocular indirect ophthalmoscope or slit lamp by microscope with Volk lenses. Okay, any problems with the direct?
No, تمام يا دكتور.
Okay, let's move on to the binocular indirect ophthalmoscope. So in the direct methods of illumination, we mentioned that the direct pencil of light, the peripheral pencils of light, cannot reach the observer's eye, so we cannot observe the peripheral field. But with the indirect, we use a condensing lens, a plus lens. This plus lens will converge more rays to fall on the observer's eye. So I'll be able to see more field of view than the direct ophthalmoscope. Okay, the image is intermediate. This means that it's between the lens plane and the observer's eye. It's inverted and laterally reversed, and the observer must accommodate to be able to see this aerial image. And this is why the direct ophthalmoscope, most of the direct ophthalmoscopes will have a low power plus lens here to act like a reading glass to make you need less accommodation. So it's for the components. There is a bulb, and then there is a binocular lenses here on that side in the eyepiece. Okay, and then there is a bit of mirror to reflect the light so that you can change the position of the eyepiece according to your IPD. The light can be halogen, or in the more modern indirect ophthalmoscope, they use LED light source. The battery can be put on the headband, or it can be put on a belt and wire to the indirect ophthalmoscope. Okay. The auxiliaries, we have a high power condensing lens, and we'll talk about that soon. We may need to use the Specular indentures, and we'll talk about that as well, and documenting charts. Those usually will come in the bag of the indirect ophthalmoscope. The condensing lens, the same principle that we used with the Volk lenses, with the non-contact plus lenses used in slit lamp biomicroscopy, they are more or less the same here. So the image is a real image. It's an aerial image between the condensing lens and the observer's eye, and it's an inverted and laterally reversed image. There are different powers of the lenses. The higher the power, so lenses, for example, with 30 diopter or 40 diopter, they are very useful to examine the peripheral retina. They are very useful to examine through a small pupil because they converge more rays of light, but they give a panoramic wide field view, but with a small magnification and small depth perception. While lenses with low power, like 20 diopter or 15 diopter lens, they need better pupil dilation. They have limited field of view, but better magnification and better striopsis. Okay? And of course, the 30 or the 40 diopter lens working distance is shorter than the one of the 20 or the 15 diopter lens. So you may want to hold this one closer to the patient's eye, but for this one or that one, you want to hold them further away from the patient's eye. Okay? The magnification, as you can see, with the low power lens, the magnification is bigger than the high power lens, but the field is smaller, and the stereopsis is better with the low power and gets less with the high power, and the focal length or the working distance is larger for the low power lens than the high power lens. Okay? We mentioned the Gallstrand principle. We want to squeeze the illumination beam and the two reflected beams of the right and the left eye through the small pupil of the patient. Okay? But they need to be totally separated. If they are completely to coaxial, I'll not be able to see through them. So we want a small separation in between them so that we can appreciate the reflected beam. Okay. So here, this diagram shows that if the patient has a high refractive error, let's say -5 or +5 refractive error, the change in the location of the aerial image will be very small. So the doctor will not need to do much accommodation to change, to focus on the aerial image of eyes with different refractive errors. This is not similar to the direct ophthalmoscope. In the direct ophthalmoscope, you need to dial the lens wheel to compensate for the change in the refractive error of the patient's eye. Otherwise, you will need to do massive amount of accommodation. But with the indirect ophthalmoscope, this is not the case because the location of the aerial image is not very far away if the eye is myopic or hypermetropic. So the amount of accommodation you want to do is not that big, and it can be easily compensated for. Is that point clear for you? حد مش فاهم الحتة دي؟
Yes, it's clear. It's quite clear. Thank you.
Clear? Okay. This is why there is no, lens wheel with the indirect ophthalmoscope. Okay, so we have many filters. We have the yellow filter. As you know, the yellow filter is always more comfortable for the patient. We have the red free filter, which is good to observe the red structure like the blood, the new vessels, the retinal nerve fiber layer, etc. Or you have the cobalt blue filter. It can be used after injecting the fluorescein dye to do an effect similar to the fluorescein angiography. So you start by adjusting the eyepiece, so you can move those eyepieces closer or further away from each other till you are having them adjusted for your IPD. What we usually do that we put our finger at the working distance here, so the aerial image is expected to be somewhere here. So I put my thumb here and I have one eye shut and I adjust the eyepiece for the left eye first, and then I have the left eye shut, and keeping the finger at the same location, I adjust the eyepiece, moving it closer or further away till I have a clear image, and then I open both eyes and I make sure that the image of my thumb is clear with both eyes. Okay. We start with low illumination and increase it incrementally. The lens should be kept about 2 inches away from the patient. It's always advised to have one finger pivoting on the patient's cheek or the patient's forehead, and then pulling the lens away from the patient's eye till you get an image. I personally start with the lens very close to the patient's eye so that I get the image of the anterior segment, and then I pull away, keeping it central till I get the aerial image and start to focus. Always think that you focus here. Okay? Start to examine the peripheral retina first and then the macula at the end. You may need to do some scleral indentation in order to see the pre-equatorial retina. So when you push the retina, you will be able to see more peripheral part of the retina, and sometimes this dynamic movement will show you a small break which is not very visible, or a white without pressure. There is a lesion in the retina called white with pressure that is not visible unless you do scleral indentation. Okay. The advantages, the main advantage of the indirect ophthalmoscope is the large field of view. This is why it's better to use the indirect ophthalmoscope for examining patients, for example, with peripheral retinal lesions, peripheral retinal breaks, etc. The second thing is the stereoscopic view, so you can appreciate heights and depth, and the light is more intense than with direct ophthalmoscope, which allows you to have better resolution of the details. The disadvantages, the technique is a bit more difficult to master. It needs a bit of coordination of the head movement, the neck movement, the hand, in order to get a good view. You need patient's cooperation. Any small movement of the light source or the lens or the patient's eye may alter the clarity of the image. The image is inverted and laterally reversed. You need to compensate for that, and the magnification is not brilliant. The one good trick that I always advise you to do, always consider the image coming from the indirect ophthalmoscope as if it's coming from a convex surface. It's not like the direct ophthalmoscope. In the direct ophthalmoscope, for example, if you see a patient, if you are looking at that part and you see a lesion here, you always have the tendency to move the direct ophthalmoscope in that direction in order to be able to see lower down in the eye. In the direct ophthalmoscope, in the indirect ophthalmoscope, it's the opposite. If you find a lesion on that part, for example, on that edge of the lens, you need to move towards that direction rather than the opposite direction. Always move the head towards the same direction of the lesion that you want to see. Okay? This is because the image is inverted and laterally reversed. A very quick hint about what we call the monocular indirect ophthalmoscope, or what's called the panoptic ophthalmoscope. It's very similar to the binocular indirect ophthalmoscope, but it uses one eye at a time. So it has a larger field of view, less magnification than the direct ophthalmoscope, but the image is upright and magnified because it has a smaller magnification and a larger field of view than the direct ophthalmoscope because it's similar to the indirect ophthalmoscope. So there is like an ophthalmoscope head, a combination of the lenses that will end up giving an erect image that goes to the observer. Okay. I'm coming towards the end of the lecture. I know you are hating me already right now. So moving to the Fundus camera, it used the same principle of the monocular indirect ophthalmoscopy. The final image is upright and magnified. You can, according to the model of the camera, you can vary the field of view or the degree of the magnification. Okay. So sometimes you may have macular photos, small field of view and large magnification, and sometimes you may want to have use a wide angle lens and and get a panoramic view of the whole fundus. The traditional fundus camera design will start up with a light source, optical filters, and then a flat mirror going through mirrors, and then the condensing lens. The light will go through the objective lens. The light is reflected through the mirror through an objective lens to go to the eye that we are taking the scans for. Then the reflected light will pass through the objective lens and through the central hole in the mirror and through a series of lenses and go to the CCD, which will record the final image. Okay. So we have what we call the observation light, and then the imaging light. So when I'm using the lens, there are two sets of light. One of them that I use to adjust the image, and then when I'm ready, I press on the joystick here, and another ray of light coinciding with the observation rays will pass through and will be emitted through the objective lens of the camera, and this is the one that is used to take the final image. So there is one that I use to adjust the image, for example this yellow one. Okay, this is called the illumination arm, and then there is the imaging, the light that goes through this donut of illumination to the patient's eye to illuminate the patient's eye, and then the light is reflected and is captured by the camera. Okay. So when the button is pressed, the mirror will interrupt the path of the illumination system and allow the lights from the flash bulb to pass inside the eye and simultaneously a mirror will fall in front of the observation telescope and reflect the light to the capturing medium or to the camera. Okay. We have modes of the fundus imaging. We have the color photograph. So the retina is illuminated with an ordinary light, and and it gives this color photograph. Then we have the red free. The retina is illuminated with a red free light with a blue light, and the reflected image will be captured by the camera. It's good, as we mentioned before, to see the red lesions, neovascularization, hemorrhages, exudates, nerve fiber layer defects, etc. Okay, and we do that regularly before injecting the fluorescein dye. Then we do the angiography. We have the fluorescein angiography or the indocyanine green angiography. Each substance, whether the fluorescein or the indocyanine, is excited with a light of certain wavelength, and when it's excited, it will emit light with a different wavelength. This is called the fluorescence. This is the principle of the fluorescence. You give one wavelength and you get another wavelength. The fluorescein angiography is better to evaluate the retinal circulation, while the indocyanine angiography is better to evaluate the choroidal circulation. So as you can see here, those are the large choroidal vessels appearing underneath the retinal pigment epithelium, because the indocyanine green has longer wavelength, and this enables it to pass easily through the melanin pigments in the retinal pigment epithelium, so that we can study the choroidal circulation better. Sometimes we do what we call the stereoscopic fundus photos. This is good for evaluating, for example, the optic disc in cases of glaucoma. It gets a slightly different image for the right eye and the left eye, and then using a special binoculars like a VR glasses or something like this, you are able to combine the two images and get a stereoscopic view or a 3D view of the lesion. The advantages of the fundus camera: it's quick and simple, and it can give a large retinal field in a single shot. High patient compliance. The image can be saved for follow-ups, and you can use dyes like indocyanine or fluorescein to do the angiography. Okay. The disadvantages: the image produced is two-dimensional, unless you will do the stereoscopic photos. The magnification and clarity is less than with indirect ophthalmoscope. Cataracts will reduce the image clarity. You have to correct for refractive errors. Usually they are not portable. High costs. The flash can cause migraine or discomfort for the patients. Okay, this will conclude my lecture. I know it was not an easy one, but I tried to simplify it as much as I could. I'll be happy to receive any questions if you have, or you want me to explain anything again. I'm more than happy to do that. Any problems now?